because this appearance, you can see, it could be just a ventricular septal defect, it could be tetralogy of Fallot, it could be pulmonary atresia with a ventricular septal defect, and it could be a common arterial trunk. I've put these at the bottom. These are more rarely, in these more rare conditions, you can also get override. We've heard about transposition and VSDs. Transposition, you can get a subpulmonary VSD, so it will be pulmonary override, not aortic override. So the way you have to make the diagnosis is you have to look for both arterial valves. So you have to look to see where the aorta is, where the pulmonary artery is before you can make the diagnosis. If the aorta and the pulmonary artery are both normal, it's possible that this is just a malalignment type of ventricular septal defect, which is quite common in chromosomal abnormalities such as trisomy 18. So if we start looking at tetralogy of Fallot, what we will see, the tetralogy of Fallot has 4 things. We see 3 of them during fetal life. So the first is a ventricular septal defect. The second is aortic override, overriding the defect, and a small pulmonary artery from the right ventricle, which indicates pulmonary stenosis in the baby. The 4th feature, which is right ventricular hypertrophy, is not something we normally see in babies before birth. Now, the 4-chamber view might be normal, but you might just see the VSD if it's large. And in many cases, as with all the conotruncal abnormalities, you might get left axis deviation. So the heart axis may look like this, so that you can see how the axis has gone more leftward. This should be pointing out more this way, and we're pointing out this way. So this is actually very common in these abnormalities, and sometimes gets detected by sonographers because they've noted that the heart axis is not normal. Then coming up, we will see the VSD and override, as you're seeing here. Okay, so this is right ventricle, left ventricle, here's the ventricular septum. Here is the ventricular septal defect, this is the aortic valve overriding the defect, and this is the aorta here. So very typical appearance. What will be variable will be the pulmonary artery anatomy. It can be just a little bit small pulmonary artery, it can be very, very small, and there can be other things. There can be other associated lesions, which can be both cardiac and extracardiac, and obviously then the outcome will be variable depending on what else you're seeing. So here is a few examples. So here's right ventricle, left ventricle, here's the ventricular septum, here's the VSD, and this is the aorta overriding. And then in this baby, the pulmonary artery is only a little bit small. So this is the pulmonary valve and the pulmonary artery, and this is the aorta here. And you can see that's just a little bit smaller than the aorta, and here is the superior vena cava. So in this baby though, this baby also had aortic override and a VSD, and you can see in this baby the pulmonary artery is quite small. We can see the pulmonary valve moving, we can see the branch pulmonary arteries, but that vessel is quite small. This is the aorta here next to it. And here is the forward flow in that artery. So although the vessel is small, there is forward flow. Now, one of the things to say is in fetal life, especially in the context of abnormalities such as tetralogy, we make the diagnosis of pulmonary stenosis based on the size of the pulmonary artery, not the Doppler velocity always, because the Doppler velocity in this setting is often within the normal range, so it doesn't help us to predict pulmonary stenosis, but we know by the nature of the lesion and the size of the vessel that there will be significant pulmonary stenosis. The 3-vessel tracheal view will be abnormal. So here we have the aorta, the SVC, and this time the pulmonary artery is looking small. So we don't have 2 great arteries of similar size. So the pulmonary artery will look small in the 3-vessel tracheal view. So just doing a sweep here. So from abdominal situs, which is normal. So going down to the abdomen, aorta, IVC, stomach here, apex here. This is left, this is right. So coming from abdominal situs up to the four-chamber view. Then from the four-chamber view, start angling up towards the aorta, and we start to see the VSD, and we can see the override. And then you get, as you go up, you also then get a view of small pulmonary artery. So that's the aorta, and we can see a small pulmonary artery here coming from the right ventricle. And there it is again, so pulmonary artery here much smaller than the aorta, we can see it branching. Okay. And then we can look at the side of the arch too, so branching PA, this is the aorta, and you can see that the arch descends to the left, so a left-sided aortic arch in this baby. And here we go, it's just the colour on it, so that's the pulmonary artery, and that's the aorta. So you can do a sweep up and down and see all those things. There can be associated lesions, so tetralogy can occur with double outlet right ventricle. In this setting, the aorta will be overriding by more than 50%, but the management is still going to be the same after birth. You can get a right-sided aortic arch. In the previous example, I stressed to you that that baby had a left arch, but we know many cases of tetralogy will have a right arch. You can have atrioventricular septal defect with tetralogy. And just for information, babies that have atrioventricular septal defect and tetralogy have a high incidence of trisomy 21. You can get anomalous pulmonary venous drainage. You can get coronary artery fistula with it. You can get all kinds of things. But the other variant that is well recognized is something called absent pulmonary valve syndrome, in which the pulmonary arteries are not small, they're just very, very dilated, so the opposite. So this is an example that had a right aortic arch. So this is right, this is left, apex is to the left, here. This is a small pulmonary artery here, coming to the left of the trachea. You can see the trachea and esophagus there. This is the aortic arch, which is going to the right of the trachea, and this is the SVC. And also you can see that the pulmonary artery is quite a bit smaller than the aorta. So this was tetralogy with a right-sided aortic arch. This is an example with absent pulmonary valve syndrome. As I said, in this condition, the pulmonary arteries are very dilated. So here is the pulmonary valve here, and these two vessels here are the branch pulmonary arteries. They're enormous. And sometimes these babies are picked up because the sonographers will say, I can see some cystic lesions in the chest, and what they're actually seeing is the very dilated pulmonary arteries. This is the aortic valve here in the center. It's called absent pulmonary valve. It's not really absent, the valve's there. It's more of a very dysplastic pulmonary valve, and it tends to be very regurgitant, which you can see here. So you get this to and fro flow across the valve, and this can be, these big pulmonary arteries can be a big problem for the baby after birth in terms of respiratory symptoms. So the management can be quite difficult for some of these babies after they're born. Most cases of tetralogy do not require immediate attention after birth. Most of them are going to be fine in the first few weeks. And for most of them, we're sort of planning surgical correction between 3 to 6 months of age. Some of them might require to have some procedure beforehand if the pulmonary blood flow is not adequate. But there will be a few that actually have very tight obstruction to the pulmonary valve that will need something doing quite soon after birth. And one of the indicators, firstly, is the size of the pulmonary artery, but also getting reverse flow in the duct. So here's another example where we have aortic override. Here's the VSD. This is a very small pulmonary artery that we're seeing here, so that's the aorta, pulmonary artery. And in this baby, we had some forward flow across the valve, so it's not atretic, but we also had quite a lot of regurgitant flow from the duct. So this baby had quite severe obstruction and did need to have early intervention after birth to establish pulmonary blood flow. Chromosomal abnormalities do occur with tetralogy of Fallot. We see a whole range of abnormalities in about just over 20% of cases. You can also have other abnormalities and syndromes, so Vactral and charge associations, pentalogy of Cantrell, various other things. So it's really important to look at the rest of the fetus. Sometimes things can't be detected before birth, but many times they can. So extra cardiac assessment, including karyotype, is very important. So then I'm going to move on to pulmonary atresia with a ventricular septal defect. For non-cardiologists, there are two settings for pulmonary atresia. Well, there's more than two settings, but the two main settings. You can have pulmonary atresia with a VSD. You can have pulmonary atresia with an intact ventricular septum, and they're two different types of problems, so you shouldn't get them confused. You can also have pulmonary atresia with more complex heart disease. So pulmonary atresia actually means that there is no flow from the right ventricle or into the pulmonary artery, right? Or there is no flow into the pulmonary artery from either ventricle. It's a complete obstruction. And in this setting, we have a VSD, and aortic override. So this VSD, very small pulmonary artery. So no patent connection between the right ventricle and the main pulmonary artery. And in this setting, sometimes you can't see the main pulmonary artery. Sometimes you can see a small pulmonary artery with no flow in it. Sometimes you can only see the branches. You can't identify the main pulmonary artery. And the branch pulmonary arteries will be filled reversely, retrogradely, from either a duct or collateral vessels from the aorta, or both. And there are occasional cases we see where there's collateral vessels that supply the lungs, and we just can't see the pulmonary artery at all, or the branches. So this is a spectrum of abnormalities, so they don't all look the same, they don't all behave the same, and they don't all have the same outcome. So at one end, it's the severe end of tetralogy of Fallot, so you can see a small pulmonary artery that looks like it's connected to the right ventricle, but there's no forward flow. Then there will be ones where you can't see the main pulmonary artery, but you can see the branch pulmonary arteries, and there are no collateral vessels. And then there will be ones where you can see both. You can see the native pulmonary arteries, the branches, and collateral vessels. And then, as I said, the severe end where you just have collateral vessels and you can't find pulmonary arteries. So at the better end of the spectrum here, so full chamber view virtually normal. As we're coming up, we see a ventricular septal defect in there. We can see the aortic override, VSD, aortic override. And in this baby, we could see a tiny pulmonary artery here, which seemed to connect to the right ventricle. And you can see it branching. But we could only see reverse flow from the duct. We couldn't see any forward flow into that vessel. It was all coming retrogradely. So this is at the severe end of the spectrum of tetralogy. This is just another example. This one has levo position again, where the heart axis is deviated a bit to the left. Full chamber view otherwise is not really very exciting, and just we're going down to the situs view in that clip as well. The situs was normal. And then coming up towards the vessels, here we are. This is the aorta, there's the VSD, and the aortic override. And then we're coming to try and find the pulmonary artery. We couldn't find a main pulmonary artery, but what you can see here is like branching vessel. It's called a seagull sign of native branching pulmonary arteries, but we couldn't connect that to the heart. So we can see the branch pulmonary arteries, but we can't see the main pulmonary artery. And you can see it again here. There's the aorta and the VSD, and these two other branch pulmonary arteries. I hope you can all see that. It's not always easy to find them. You have to search for them sometimes. So what we have to do when we see them is try and identify what is the pulmonary blood supply. Is it coming from the duct? Is it coming from collateral vessels, or both? So here we have retrograde filling here of the pulmonary artery. This was in fact a very curly duct that was filling pulmonary arteries here. Here's another one. These are the branch pulmonary arteries. This is the aorta. So pulmonary artery is much smaller than the aorta. And again, we're getting retrograde filling. It was retrograde filling coming in and then going up here. So we can see collateral vessels. So you can see them in a sagittal view. Here's a view of the aortic arch and descending aorta. And we can identify one collateral vessel here. They're not always easy to see, but we can see it there. And in this baby, what you're seeing is here are the branch pulmonary arteries. Couldn't see the main pulmonary artery. This is the aorta next to it, and when we use the colour, we're seeing lots of flow in the chest. And this baby had a lot of collateral vessels which were actually supplying the pulmonary arteries, or the pulmonary blood flow. So there's a whole spectrum of abnormality here. They can look quite different. This lesion can also occur with other abnormalities, chromosomal, about 17%, maybe a little bit more. Many of these will have 22q deletion, but it does occur with other abnormalities too. And it can also occur with other abnormalities with normal chromosomes. And so very important to look at the whole baby in detail. And then just finally, in this group of abnormalities, common arterial trunk. So a common arterial trunk is a single great artery arising from the heart, which gives rise to the aortic arch and the pulmonary artery, and also the coronary circulation, actually. So this is just a drawing of it. We have a common one valve, one arterial valve, and then it gives rise to the aortic arch and the pulmonary arteries, and the trunk overrides a VSD only. So fortunately, you might appear normal, you might see the VSD, you might have a dominant ventricle. The cardiac position, again, could be abnormal, so lever position is very common in all conotruncal abnormalities. So here is an example from a baby that had a trunk, and you can see that's the four-chamber view, and we're coming up and we're seeing a large great artery and a large arterial valve here. So we'll have a single trunk that gives rise to the aortic arch and the pulmonary artery. These are just still images, so the single trunk comes out, there's the truncal valve, gives off the aortic arch, you can just see head and neck vessels here, and it also gives rise to the pulmonary artery, which you can see coming off the side here and branching. And this is the moving image of the same one, all right? So here is the trunk coming off, goes around to form the arch, head and neck vessels, and here is pulmonary artery coming off the side, and if you watch it, you just see it branching as we're sweeping around. Here's another example, again, some axis deviation. Heart looks a little bit big, but otherwise the four-chamber view is not that remarkable, really. And here we have a view of the trunk. So that's a truncal valve, the valve of the artery, is giving rise here to the aorta, and from the side here, artery. So the valve is here, and then that artery is arising quite close to the valve. So in a trunk, there can be variation. The truncal valve, it can be it's abnormal, but it can be dysplastic. It can have stenosis, so an obstruction. It can have regurgitation, and those types of things are going to influence the outcome for the baby. So this is a baby that has a trunk, a big artery coming here, and if you look at that valve, the valve leaflets look very thick and dysplastic. So a dysplastic valve, you can just about see the pulmonary artery coming off the side there. And this baby has, as you can see, turbulent flow. This baby had truncal valve stenosis, but also has some regurgitation, which you can just see. It's caught in the still image there, but you can just see it there, the red flow. So the flow across it is stenotic, and there is some regurgitation. So these things are going to influence the outcome. So a trunk can also occur with other things. You can have coarctation with it, you can have an interrupted arch with it, and as I said, you could have one ventricle is bigger than the other, so it does occur in different settings. This condition is also associated with other abnormalities, both chromosomal and extracardiac. So I think the message for all the penile abnormalities is you must think about the whole baby, you must think about karyotyping, and you do need to look carefully to exclude any extracardiac problems. Okay, so that's all I was going to say, but if you have any questions, I'm happy to take them now.
We continue with the live stage. Gestation 23 weeks with the proportion of the right ventricle,
Hi, okay. So this is the abdominocytes. So that's the left side. This the left side here. This is the right stomach. Aorta, and then you see the portion of view. And what is obvious here? You can see this brown thing that I showed you earlier here, and you go
dividing. One vessel goes in the direction of the arm, the other vessel goes closer to the spine up. So I think it's just brachiocephalic trunk that's bigger than the rest.
But then what do you think about the arch here? Look.
Được.
There. You think a bit small
Nó ra
than
cái bệnh
usual?
Of course, you can measure it, but you can see that it looks smaller, and you have like diastolic flow. I think it is. Can you put a pulse wave into the arch?
Here?
Somewhere at the junction. Yes, you see this diastolic flow. It's quite typical also when they have a real aortic arch problem, that there is a forward flow, but there is also a diastolic wave.
Cái này là người ta nói tới cái lớp lơ mà tâm trương á. Khi mà bỏ vô cái chỗ eo động mạch chủ á, thì mình sẽ thấy được cái lớp lơ tâm trương đó thì chứng tỏ là nó có hẹp eo.
Coi đi. Cho coi đi.
Chạy cái nó phục ngược lại nó
À thì sao?
thì nó có hẹp eo,
À,
tại vì nó chảy ngược lại.
yeah.
And is it possible to get the sagittal?
Yeah, try this now. Again.
I think the case is a little bit confusing because we just said a couple, maybe minutes, but maybe hours ago that LSBC is not associated with coagulation.
You can see there's the 4 vessels instead of 3 one.
Yeah.
Mình thấy cái này có 4 cái mạch máu này. Thì cái nhìn đó là có cái SCC.
Then you can see there's
Thì bác là
right
Ừ, đúng rồi. Persistent left. Persistent rất là persistent.
Hai cái vòng tròn.
Anh có cái kia cũng bị nữa chứ, mà kia quay này phải coi gỡ cái đèn thấp.
I try to get this sagittal view.
Yeah, but I think it's also important that people can see that the sagittal view is not tricky, and sometimes you are really difficult to get.
Nói là đó, đôi khi cái mạch cắt sagittal view nó rất khó cắt, để mà cái dựa lên những mạch cắt khác, chứ không phải lúc nào mình muốn cũng được hết trơn á. Không phải lúc cái thai nó khác cái mấy đứa bé đẻ ra rồi, không phải mình muốn cắt mà cắt nào ra mà cắt đó.
Corona sao cái corona.
Yeah, but you know, in this while ago, you could see the distance quite well. In this, we have this kind of view, right? You can see where the distance is, and you can see that it's rather smaller than the duct in this kind of view.
về khó
Không ngay chứ, không ngay chứ.
còn như vậy nó lại và nó dễ nghe
Ừ,
nó khó.
đúng rồi. Đó, nó không phải là Anh Quốc, mà là nó dễ hiểu, không bật sạc lăng đó để hiểu được. Kiểu nó khó. Việc cũng như là cái vụ vỗ đó.
What is the age of this?
chuyên cắt vào này. Ủa, thì nó bao nhiêu thì mà là hình như là nó có đối với từng ông đó ông nó nhỏ ông còn mạnh thêm đó. Ông không giỡn, ông cắt chuyên cắt đó. Có người ta làm nữa đâu, không thấy là người ta làm nữa. Bà mới lên đây là thầy cũng khôi đó.
Ai cũng thử.
Mình nói ông khôi bà này có giáo sư không? Nó không, bà này có giáo sư. Nhưng mà bà thầy có phó giáo sư là tôi là bà là giáo sư.
You know, sometimes it's just very difficult, right? So I think this is one of cases like this. Very difficult to get an answer.
Can we continue with the talk first?
And so far as me, I think I'm the first person to have it uploaded in the system. Yeah, I don't think it's on your computer.
Giờ này là nó là xem phim là mỗi tên tiểu nội qua phim cũng dân xem phim gì từ bộ này là bộ phim nhi đó, chứ không phải đạp dược, không phải đạp y dược. Bộ mô và đây không phải đạp y dược, đạp y dược là cảm giác không có bệnh viện thôi chứ không phải đạp y dược.
I thought that would be like a cruise, you know, lecture. I will upload my presentation as it should have the first. It would be quicker. It would be nice to have some kind of pointer too. Oh yeah, so.
Là thì chiều ta đúng là đầu thao tội nếu bà chấp nhận thôi, bà có chơi đâu dịch sang giá trị bà đúng rồi, cho nên nó mất thời gian bắt đầu Ủa bà đi mà bị cái cát này thì bà cát này bà sạc lon cát đó ông giật này bà sạc lon đúng là bà nó không có mặt ở Sài Gòn. Hả? Ồ đúng là Nga diễn chứ. Tức là bà đưa nhưng mà cái DVD này hay á, bà nói dễ nhất. Bà nói dễ hiểu nhất. Bà nói ngành bà nói dễ hiểu. Đây bà là gì cái gì nhưng